This video will be about thyroid gland, and we'll be discussing about the synthesis, the functions of thyroid hormone, how the thyroid hormone is regulated, and finally the disorders which are associated with thyroid gland. So to begin with, here we have a histologic section of the thyroid gland, which contains the thyroid follicles with the thyroid cells. And these thyroid cells are responsible for the secretion of T3 and T4, which are our thyroid hormones. And apart from it, we have the parafollicular C cells, and they are responsible for secretion of another hormone, which is related to the calcium metabolism, that is calcitonin. The thyroid follicles enclose a stroma inside them. So the yellow colored one shown here is the stroma of the thyroid follicles. Now let's move into the synthesis of thyroid hormones. So the thyroid hormones are made up of two parts, that is thyroglobulin and iodine. From where do we get the iodine? The iodine is received from the diet, whereas the thyroglobulin, they are produced from the endoplasmic reticulum and the Golgi apparatus of follicular cells. So the endoplasmic reticulum and the Golgi apparatus, they are responsible for the synthesis of thyroglobulin. Now the iodine inside the blood, it is going to be in the reduced form. This iodine must enter into the follicular cell or the thyroid cells, right? How do they enter? They enter via a symport, which transfers one molecule of iodine and along with that one molecule of sodium to balance out into the thyroid follicular cell. And this symport is called as the sodium iodide symport, that is the NIS. And this is a secondary active transport mechanism. So this is a secondary active transport mechanism. And by this, what happens is that the iodine enters into the cell. Now, the iodine and thyroglobulin must combine. However, the iodine here is in the reduced form. It must be oxidized. And for oxidation, we require another enzyme, and that is actually present on the apical end. Here we know that this is our colloid. So this region is the apical end of thyroid follicular cell, whereas the region closer to the blood vessel is the basolateral end. Now in the cell membrane of the apical end, we have another oxidizing enzyme, that is the thyroid peroxide. Also short form we'll write it as TPO. What happens is that the reduced iodine is transferred into, or it's excluded out into the stroma with the help of another transporter. Here we have another transporter, and that transporter is actually an antipode. That is, it will transport one molecule of chloride into the cell and it excludes out the iodine out of the thyroid cell. Now why does the chloride enter? That is, it enters to actually maintain the electrical balance. One negative charge goes out, so another negative charge, that is the chloride, enters to maintain the electrical neutrality. And the thyroid peroxidase, we know that it oxidizes the iodide into the iodine. The next step is the combination of iodide with our thyroglobulin molecule. So the tyrosine present inside the thyroglobulin will bind with the iodine, and that will lead to the formation of MIT, that is monoiodotyrosine. The next step, and this monoiodotyrosine, what will happen is that it will again combine with another molecule of monoiodotyrosine to form a diiodotyrosine. And these mono and diiodotyrosine actually combine themselves or undergo a coupling reaction to form our T3 and T4. So what are the reactions actually happening? When one molecule of MIT combines with one molecule of DIT, so 1 plus 2, what do we get? We get the T3 thyroid hormone. Now what happens when one molecule of DIT combines with one molecule of another molecule of DIT? Well, we know that 2 plus 2 is equal to 4, so we get the T4. Now there is a third one, that is what happens when one molecule of DIT combine with one molecule of MIT. This is actually not just a simple addition reaction, it's actually a chemical reaction involving chemical bonds. So this will actually lead to the formation of a third compound, and that is called as reverse T3. Now T3 and T4 are actually the active forms. Now let's speak a few words about T3 and T4. So T3 is actually the active form, and it is responsible for the physiological functions. However, it has a very rapid action, and therefore it has a very short half-life. The half-life of T3 is very short. Once it is released into the bloodstream, it immediately undertakes a physiological action. Compared to that, what happens is that the T4 actually, if it is secreted out in the peripheral tissues, what happens is that the T4 gets converted into T3. That is what is actually happening to the T4. And it has a very slow action compared to T3. and therefore it has a long half-life. Here we have a short half-life, here we have a long half-life. So what is the advantage of having a long half-life? Because of having a long half-life, in thyroid deficiency, which would be better to give, T4 or T3? The answer would be T4, because otherwise, since T3 has a short duration of action, we'll have to take the thyroid drugs again and again. Since T4 has a longer duration of action, we only need to take the drug once compared to T3, where we'll have to take the drug again and again to maintain the thyroid level. So that's about T3 and T4. So let's summarize the steps of thyroid synthesis. So the first step is thyroglobulin synthesis by the endoplasmic reticulum and the Golgi apparatus. What is the second step? The second step, that is the iodide must enter into the thyroid cell, and that is called as iodide trapping. That process is called as iodide trapping. And in the third step, what happens is that the iodide is oxidized into iodine. So oxidation of iodide occurs, and then there is the combination to form the monoiodotyrosine. So there is formation of monoiodotyrosine. Then they undergo the coupling reaction. So that's how the thyroid hormones are formed. Now, how are they released? So here we said that the thyroid hormones are formed, right? So these are our 3 thyroid hormones. How are they released? They're actually stored in the colloid. And when there is a deficiency or when there is a need for the thyroid hormone, what happens is that these stored thyroid is released back into the thyroid gland and they enter into the bloodstream. This process occurs with the help of pinocytosis. So pinocytosis means that pinocytosis means that the apical surface will send out pseudopoda, and this pseudopoda will capture the T3 and T4 in vesicles, and by that the T3 and T4 will enter into the cell, into the thyroid cell. And then what happens is that the lysosomes will fuse with the T3 and T4, and they are broken down from the vesicles, and the enzymes are released into the bloodstream. So that's how T3 and T4 enters into the blood, and the ratio is actually T4 is to T3 is equal to 10 is to 1. Therefore, T4 is released 10 times compared to T3. So that's about the synthesis of thyroid hormone. And now let's move into the function of thyroid hormones. So the thyroid hormone function is by the T3, the physiological action is by the T3 hormone. And we can divide roughly the functions into systemic functions, and it affects various organs. Almost all of the systems of our body are affected by the thyroid gland. It's a very important hormone for our function. And then we have the action on metabolism. So under metabolism, we'll be discussing its effect on carbohydrate, then the effect on the fat metabolism, the protein metabolism, the vitamin metabolism, and the calcium metabolism. And we'll also see what happens to the skin. So let's begin. So the thyroid hormone, it is a calorigenic hormone that increases the basal metabolic rate. In a nutshell, this is a function which thyroid gland produces on all the cells of our body, that it increases the oxygen consumption, it stimulates the metabolic activities, and it also lead to the production of heat. So there will be heat production, there will be increased oxygen consumption of cells, and they do this by increasing the activity of the sodium potassium ATPase of cells. This is how they increase the basal metabolic rate. Now coming to the carbohydrate metabolism. So in carbohydrate metabolism, they will increase the gluconeogenesis. Gluconeogenesis is enhanced. They will increase the GI absorption of glucose, and they will also increase the glucose uptake. Now coming to the fat metabolism. On fat metabolism, it increases the fat mobilization from the adipose tissue, and then it increases thereby it increases the free fatty acid concentration is increased in the plasma, and then it increases the fatty acid oxidation. These free fatty acids are oxidized, and there is a special when it comes to the cholesterol level. So the cholesterol levels are actually lowered by thyroid hormone. How do they lower it? They lower it by increasing the bile excretion of cholesterol. So biliary excretion of cholesterol is increased. So what is the importance? The importance is that in hypothyroidism, what will happen? The cholesterol levels will be increased, and that predisposes to atherosclerosis. Now let's move to the protein metabolism. In protein metabolism, at normal levels, it is anabolic in nature. which increases the protein synthesis and RNA synthesis, whereas at higher levels it becomes catabolic. At high levels it actually leads to protein breakdown, so it becomes a catabolic hormone. What about vitamins? So we said that the basal metabolic rate is increased, right? Which means that the enzymatic activity of the cells are increased. So when the enzymatic activity is increased, there is going to be an increased demand of coenzymes, which is the main function of vitamins. Vitamins are mostly coenzymes. So there is an increased demand of vitamins in hyperthyroid patients, or when the thyroid activity increases, the demand for vitamins are increased. Now coming to the calcium metabolism. In calcium, what happens is that from the bone, the calcium and phosphates are absorbed. And what does this lead to? In hyperthyroidism, this predisposes to osteoporosis. Now, what about the skin? In skin, we said that in hypothyroidism, there is going to be catabolic action on the protein metabolism. As a result, what happens is that there will be accumulation of protein complexes in the skin. And these protein complexes will lead to water retention in the skin, and that is the reason for puffy skin. There is dry puffy skin which is seen in hypothyroidism. So that's about the metabolic functions. Now let's move into the systemic functions of the thyroid gland. To begin with the heart, it has a direct effect and it has an indirect effect. Now what is the direct effect? The direct effect is that it increases the sensitivity of beta receptors, it increases the amount of beta receptors, and it increases the sensitivity of beta receptors to noradrenaline and adrenaline. And the indirect effect is that it stimulates the sympathetic system. So sympathetic activity or adrenergic stimulation occurs. And as a result, what happens? Because of these functions, the heart rate is increased. There is a tachycardia, or heart rate is increased by the action of thyroid gland. Therefore, in hypothyroidism, that is when the T3 or T4 decreases, what happens? There is going to be decrease in heart rate. Whereas when there is an increase, that is in hyperthyroidism, the patient will manifest with tachycardia, that is increased heart rate. And there is an additional function that is on the myocardial contractility. In the myocardium contractility, what happens is that the alpha MHC action or expression is induced, and as a result, the contractility of myocardium is increased. So these are the functions which happen on the heart. Now let's move into the blood pressure, or what happens to the blood vessels. So in the blood pressure, we know that there are two elements, right? There is the systolic blood pressure, and then we have the diastolic blood pressure. And because of these two, we have the pulse pressure as well. Now, for the systolic blood pressure, we said that the heart rate, when we spoke about the heart, we said that the heart rate increases and the contractility also increases. Therefore, in a nutshell, what happens is that the cardiac output increases. So the cardiac output is increased due to the action of thyroid hormone, and as a result, there is an increase in the systolic BP. What about the diastolic BP? We said that the thyroid gland produces heat, right? Now, heat activates heat mechanisms, and heat actually produces vasodilation of cutaneous vessels. And as a result, what happens? Because of vasodilation, the peripheral resistance will decrease. And the diastolic BP is actually controlled by the peripheral resistance. If the peripheral resistance decreases, diastolic BP decreases. And if the peripheral resistance increases, diastolic BP increases. So what happens to the diastolic BP? The diastolic BP decreases. So what are we seeing here? We have an increased systolic pressure, which is controlled by the increase of cardiac output. And we have a decrease in diastolic blood pressure. So what will happen to pulse pressure? Pulse pressure, which is the difference of systolic and diastolic BP. The pulse pressure will obviously increase. So there is an increase in the pulse pressure. So that's the effect on the blood pressure. Now let's move into the GIT. So in GIT, what happens is that they will increase the appetite. So there will be, because of increased metabolism, increased oxygen consumption, the person will require, there will be an increased appetite, and there will be a need to intake more food. And apart from that, it will also increase the GI secretion and the GI motility. So now we can say what happens in hypothyroidism and hyperthyroidism. In hypothyroidism, what will happen? In hypothyroidism, the appetite is decreased, which will lead to anorexia. The GI motility is decreased, so that will lead to constipation. Whereas in hyperthyroidism, what will happen? The appetite is increased, so the person will need more food, or the food intake is higher, and the GI motility is increased. What happens when the GI motility is increased? When the GI motility is increased, there is going to be diarrhea. So that's the action of thyroid on GIT. Now we move on to the respiratory system. In the respiratory system, what happens is that the oxygen, as we have said, that the BMR is increased, right? So the oxygen consumption is increased. Also, because of metabolism, the cells will produce large amounts of carbon dioxide as well. So there are going to be increased oxygen consumption and carbon dioxide production, and they will act on the brain, and they will increase the rate and depth of respiration. Apart from this, there is also erythropoietin stimulation, so that the oxygen carrying capacity is increased. So erythropoietin stimulation also occurs. Now finally coming to the CNS. In the CNS, it has a very important role, especially in the fetal life. The thyroid hormone has a really important role which is required for the normal functioning of brain. So what are the effects? In the CNS, the first one is the formation of synapses. So the development of synapses requires severely or seriously requires thyroid hormone. And then there is the branching of axons to form dendrites. So dendritic development or dendritic formation. And it also controls the reflexes. So the duration of reflexes or the reaction time of reflexes are controlled by the thyroid hormone. And finally, for the myelination of nerves. So all these four functions are extremely essential for the development of our central nervous system. And that is why in hypothyroidism or in congenital hypothyroidism, there is going to be mental retardation. Now we move on to the remaining systems. So here we have the sleep. So what happens to the sleep? Thyroid hormone actually activates the reticular activating system. It acts on the reticular activating system, and as a result, what happens? The person is more active, and which means that in hyperthyroidism, when T3, T4 levels are increased, the person is unable to sleep due to hyperactivity. So he's going to face insomnia. Whereas in hypothyroidism, the person will have excessive sleep and lethargy, and that is called as somnolence. What about the skeletal muscles? We said that the thyroid hormone has an anabolic effect at the normal levels. At both the ends, that is at hypo and hyperthyroidism, it's going to have a catabolic effect, which means that there is going to be protein breakdown in the muscles, and that will lead to muscle weakness. Coming to the reproductive system. In the females, so the reproductive system of females, the thyroid hormone regulates the menstrual bleeding. So in hypothyroidism, what happens is that there is going to be excessive bleeding or abnormal uterine bleeding in excess occurs. Whereas in hyperthyroidism, the opposite happens. That is, there is going to be reduced menstrual bleeding. So the menstrual flow is controlled. This is the case of females. In case of males, the libido and impotence. So in case of males, what happens is that libido is seen in hypothyroidism, whereas loss of libido, whereas impotence is seen in hyperthyroidism. So there is going to be a dysregulation of sexual function in both males and females. Among the endocrine activity, the first one is the effect on the growth hormone. It will potentiate the effect of growth hormone as well as it increases the growth hormone production. So there are two effects: increases the production and increases the sensitivity of cells for cells to growth hormone. Therefore, we can say that the thyroid hormone is actually a growth promoting hormone. This is why thyroid hormone is essential for children and fetus. It is essential for their bone development, for their cartilage ossification, and also for their skeletal muscle maturation. The prolactin secretion is enhanced, so thyroid hormone increases lactation. And since the metabolism is increased, in general, the tissues are in need of hormone. So we can say that in general, there is going to be an increased demand for hormones due to the activity of thyroid gland. So that sums up the multi-system action of thyroid hormone, which shows us that the thyroid gland is an extremely important gland, or the thyroid hormone is extremely important for the normal physiologic function of a human body. So how does the regulation of thyroid gland occurs? So we have the hypothalamus. So the axis which controls is the hypothalamo pituitary, which is anterior pituitary, and the thyroid axis. This axis is responsible for regulating the secretion of thyroid gland. It is going to be the hypothalamus, which secretes the thyroid releasing hormone, which is TRH. And the TRH acts on the anterior pituitary, which will release the TSH, that is the thyroid stimulating hormone. And this thyroid stimulating hormone is going to act on the thyroid gland. And in the thyroid gland, it increases 3 steps. That is, it increases the vascularity of thyroid gland, which provides thyroid with more iodine, as well as more, it provides an opportunity to release thyroid hormones into the bloodstream. And it also increases the iodide trapping, that is the uptake of iodine into the thyroid gland, which is the first step in synthesis. And because of these 2 steps, in general, what happens is that it increases the secretion of T3 and T4. That is, the thyroid hormone synthesis is enhanced by the thyroid stimulating hormone. Now, the excess of T3 and T4, it has a negative feedback effect. So the T3, what happens is that it will inhibit the TSH secretion. So the TSH secretion is inhibited by the excess T3. And not just the TSH, it will also act on the hypothalamus, and it will inhibit, there is going to be a negative effect on the release of thyroid releasing hormone. So both TSH and TRH secretion is decreased, and this is called as the negative feedback. In addition to that, there is an auto-regulatory mechanism that is dependent on iodine. When the iodine is excess in diet, so what happens is that the sodium iodine symport, which causes iodine trapping, will be inhibited. As a result, what happens? The iodide trapping is decreased and iodide synthesis is inhibited, right? And the opposite also occurs. That is, when the iodide is deficient in the diet, the activity of these NIS will be enhanced so that more iodide trapping occurs. This is actually an auto-regulatory mechanism. This is an auto-regulatory mechanism by the thyroid gland itself. And the phenomena has a name, and that is the Wolff-Chaikoff effect. So that's about the regulation. Now we move on to the last section, which is the disorders of thyroid gland. So the disorders of thyroid gland are roughly hypothyroid disorders. And then we have the hyperthyroid disorders due to excess secretion. And the hypothyroid disorders, hypothyroid disorders could be cretinism in children or myxedemia in adults. And under hyperthyroid, we'll be mainly discussing Graves' disease. What are the features of hypothyroidism? We have already discussed this. Now, there are several reasons why myxedemia occurs. The first one is because of lack of iodine in diet. Or iodine might be produced, but there may be a defect in the thyroid gland which we do not know, which we'll say as idiopathic. Or there is a condition, there is an autoimmune condition known as Hashimoto thyroiditis. So Hashimoto's disease, where the thyroid gland is destroyed. So it's an autoimmune disorder. In all these conditions, we have hypothyroidism. So what are the features? There is a mnemonic for that. The answer is that if we know the functions, then we'll know the disorders. So to know the physiologic functions are extremely important. The mnemonic is A, B, C, D, E, F, G, H, I. So let's start. A stands for 2, that is anorexia and atherosclerosis. B stands for bradycardia. C stands for cold intolerance. Why is cold intolerance? Because the VMR and heat production is reduced. There is also constipation because GI motility is reduced. Why bradycardia? Bradycardia is due to decreased heart rate. Anorexia is due to decreased appetite, and atherosclerosis is due to decreased secretion of cholesterol in bile. And D stands for dry skin. We have said that the protein complexes in skin are formed which lead to water retention and dry skin, and that will also lead to, due to water retention, there is going to be edema. F is fatigue and tiredness. One of the reasons is because of the muscle weakness, because of catabolic effect, and also the sleep is increased, right? So these two will cause a fatigue. And there is going to be a weight gain. Why is there a weight gain? The reason is obvious, because the metabolism is reduced. Therefore, the patient will have a weight gain. And then there is hair loss. And finally, the reproductive system is affected. It could lead to infertility and abnormal uterine bleeding. So those are the features of myxedema. Now, cretinism. Why does cretinism occur? Cretinism can occur due to, first one, there is an congenital absence of the thyroid gland, which is the first reason. The second reason could be, it may not be directly the thyroid, the pituitary gland is affected. So there could be a hypopituitarism, something that is affecting the pituitary gland. Or there could be maternal antibodies to the thyroid, maternal antibodies to the fetal thyroid. Or there could be a fetal dysgenesis of thyroid gland. And we have said that the most important function of thyroid in newborn is for growth and for CNS development. So the main presentation is going to be mental retardation. The child is going to be mentally retarded, and the child is going to be obese, shortness due to the stunting of the skeletal growth, and the child's sexual development is diminished because of the effect on reproductive organisms. And finally, the child will have a large tongue, that is macroglossia. So that's about cretinism. Now moving on to the last topic, which is hyperthyroidism. So what is Graves' disease? The Graves' disease here, what we have is TSH stimulating hormones. So here we have TSH stimulating antibodies. Antibodies will be, it's an autoimmune condition where our body produces antibodies which have the function or which mimic the function of TSH, thyroid stimulating hormone. And as a result, they will act on the thyroid gland. And as a consequence, there is going to be increased formation of T3 and T4. So to understand the features of hyperthyroidism, we can take an example of a person who is doing a workout or an exercise. What happens to people who during exercises or workout? First thing which happens is that they are going to have tachycardia, right? Their heart rate is going to increase during exercise. If we understand a person in exercise, we'll understand what happens during hyperthyroidism. And there is going to be heat intolerance because of increased BMR, basal metabolic rate. And because we know that a person who exercises will have weight loss. And severe exercise will lead to muscle weakness. Muscle weakness here is actually due to catabolism. And the reticular activating system is activated, so the patient is unable to sleep, leading to insomnia. Muscle weakness or tremors can occur. Why tremors? Tremors are actually due to the effect on the CNS. Now the reflexes are enhanced, so the reaction time of the person is exaggerated. And finally, there is going to be a feature that is exophthalmos. Exophthalmos is the protrusion of eyeballs. What is exophthalmos? It is the protrusion of eyeballs. Why are eyeballs protruded? The eyeballs are actually protruded in hyperthyroidism because of retroorbital edema. Edema occurs behind the orbit, and that will push the eyeballs, leading to its protrusion. What is the problem with the exophthalmos? The problem is that the eyelids cannot close. As a result, what happens is that the cornea is exposed to the environment always. And when the cornea is exposed to environment, it actually leads to the dryness of cornea. And the cornea becomes dry. And this cornea is dangerous. That is, it is susceptible to infections. Ultimately, ulceration may occur, and even it may lead to blindness. So that's about hyperthyroidism, and that's in general about the thyroid gland.